Now we are going to begin talking about the different syndromes related to aphasia. We have already implied that many language variations occur in aphasic patients. These variations are often very discrete and can be referred to as syndromes. The different aphasia syndromes are linked to damage in different areas of the central left hemisphere. We're going to begin by speaking about the different fluent aphasia syndromes. We learned in the last lecture that fluent aphasias result from damage to the posterior speech areas. The three forms of fluent aphasia are Wernicke's aphasia, anomic aphasia, and conduction aphasia. Wernicke's aphasia was discovered in 1874 by German neurologist Karl Wernicke. He presented information on two of his patients who had relatively fluent speech and the intonation and pace appeared normal, but their speech contained unusual semantic features. The patients would frequently use elaborate descriptions called circumlocutions instead of simple words. It often contains many phonemic substitutions, and in severe cases, spoken output can be composed of incomprehensible and incoherent utterances that are fluent, well-articulated, and phonologically correct. These are known as jargon, and they're essentially nonsense words. Individuals with Wernicke's aphasia also have a reduced ability to comprehend the speech of others and themselves. And also, their reading aloud skills are often poor, but occasionally their reading comprehension may be stronger than their verbal reading skills let on. So this can actually help us a lot with treatment of individuals with Wernicke's aphasia. So I'm just going to digress for a minute. I just want to say that in terms of performing a differential diagnosis of an individual with an aphasia syndrome, one tool that is really helpful during assessment is to assess their repetition skills. In individuals with Wernicke's aphasia, the repetition is impaired as a result of their impaired comprehension skills. So now we're going to look at a speech sample from an individual with Wernicke's aphasia. I want you guys to be on the lookout for circumlocutions, that's the roundabout speech we mentioned earlier, phonemic substitutions, the use of jargon as well. I'm not going to read the whole thing, but the part where she says, I can't mention the tarapoi. So that's an example of using jargon. She also has the phonemic substitution where she says, I have to run around, look it over, tribbing on all that stuff. Instead of saying tripping, she says tribbing. So that's an example of a phonemic substitution. And also the overall message that she delivers. She never quite answers the question, what brings you to the hospital? This is due to her lack of comprehension in the question, likely. So the next fluent aphasia that we're going to talk about is anomic aphasia. Individuals with anomic aphasia have otherwise almost normal language, but their language is marred by word retrieval deficits. Their auditory and reading comprehension is usually near normal, but their inability to produce substantive words is evident in writing as well. When the individual with anomic aphasia is searching for a particular word and is given that word, he or she usually recognizes it immediately and can take advantage of it momentarily and use it in their speech. Therefore, her repetition skills are usually better than her spontaneously produced speech. I just want to take a minute to make something clear to all of you. So word retrieval problems are common in all the types of aphasia. However, in anomic aphasia, the word retrieval deficits are the most apparent symptom. Okay, so now we're going to look at a sample from an individual with anomic aphasia. They're looking at a pretty famous picture from the Boston Diagnostic Aphasia Examination called the cookie theft. And the individual is asked to describe the picture. So something that should stand out to you is that this individual is presenting with nearly typical sounding language, but it's full of word finding deficits, significant ones. So, for example, the individual can't think of the word kitchen. He's saying a place that this is mostly in, But then when the examiner prompts him and gives him a verbal cue, he says, could you name the room? Not a bathroom. Then the individual comes up with the word, oh, kitchen, kitchen. The last fluent aphasia that we're going to discuss is conduction aphasia. In individuals with conduction aphasia, their comprehension of language is intact. The individuals make frequent but unsuccessful self-correction attempts. So they're aware that they're producing errors, but they're not really capable of resolving those errors. Their speech is marred by what is known as phonemic paraphasias. So those are inappropriate sound errors in words. For example, they might say Sadie instead of Susie, or they could produce the sounds out of order. So say Sisu instead of Susie. They also produce semantic paraphrases, which are using inappropriate words. So they mean to say chair, but they say table instead, or they mean to say table and they say chair instead. And I just want to say that it is rare, but in severe cases of conduction aphasia, the errors can occur frequently enough that it makes their speech incomprehensible. So as with the other aphasias that we spoke about, now we're going to speak about the repetition skills in individuals with conduction aphasia. So a hallmark of this syndrome is a disproportionate inability to repeat or make use of verbal cues supplied by others. So in other words, their repetition skills are quite poor. So now, just as before, we're going to look at a sample from an individual with conduction aphasia. This individual is looking at the same cookie theft picture that the individual with anomic aphasia was looking at. So some of the things that I want to point out to you is that this individual is aware of their errors. First they say the water is falling, then they self-correct to say it's flowing all over the place. And I'd also like to point out to you one of the phonemic paraphasias is the individual says strool instead of stool. We're now going to move on to the non-fluent aphasias. If you noticed, I switched the color from blue to pink. That way you guys have a little bit of color coding. So all the non-fluent aphasias are going to be with the pink header. And I just want to remind you guys that damage to the frontal lobe is what's going to result in a non-fluent aphasia. Remember, in the last presentation, we spoke about the anterior language area. So damage to the left frontal lobe causes non-fluent aphasia. In 1861, the French neurologist Paul Broca presented data from a patient called Tan, or Tan-Tan in the literature, as tan was the only syllable he was able to produce. Tan repeated the message tan as necessary with good intonation, as if to convey a message. His comprehension was relatively spared, and he appeared irritated if he could not get his message across. So a post-mortem examination of his brain showed a lesion, or the area of damage, and it was confined mostly to the lower areas of the left frontal lobe of his brain. And that's how this area became known as Broca's area. Broca's aphasia is a non-fluent aphasia. It's characterized by a paucity of speech or a scarce amount of words, difficulty in word retrieval, labored and slow rate of speech, and agrammatism. In agrammatical speech, small grammatical elements such as the, is, and on are omitted, resulting in what sounds like telegraphic speech. And when I say telegraphic speech, I'm referring to back when telegrams were used. They would just send like those really short messages that had just the important content words, and all those function words that don't really have the lexical meaning were left out. Writing skills are also impaired in individuals with Broca's aphasia because most individuals who have Broca's aphasia also suffer from a right arm and leg paralysis, and their comprehension of written and spoken words are generally intact. An individual with Broca's aphasia usually has weaker repetition skills because their repetitions are marred by those fluency problems we spoke about earlier. Now we're going to look at a language sample from an individual with Broca's aphasia. It's a question and answer scenario. So a clinician asks, what happened to make you lose your speech? The patient answers, head, fall, Jesus Christ, me no good, oh Jesus, stroke. So what I want to point out to you with this sample is that as you can see, all those smaller function words are omitted, and just the more important content words are present. It's that telegraphic speech. So he says head, he says fall, he says stroke. Then in the next segment, I'm not going to read that out loud, but you see that he is answering the question appropriately, or attempting to at least. He's trying to convey, like, he knows exactly what time he goes to each services, and he's trying to convey that information to the therapist. And what that does is it shows us that he does understand and comprehend what's being asked of him. So it appears that he knows exactly what he wants to say. He's just having a hard time getting the message out. This brings us to mixed and global aphasia. Earlier we spoke about the fluent aphasias, which occur due to lesions in the posterior language areas of the brain. Then when we switched to our pink header, we started talking about the non-fluent aphasias, which occur due to lesions in the anterior language parts of the brain. Now we're going to speak about mixed and global aphasia, like I said, and those occur due to lesions in both the anterior and the posterior language regions of the brain. Mixed and global aphasias are non-fluent aphasias, and there is a distinction between the two. It's typically made based on the basis of the severity of the presenting problem. So mixed aphasia refers to an aphasia that involves both comprehension and production, but is no more than moderate in severity. Global aphasia refers to severe comprehension and production deficits. Global aphasia results in both the scarcity of speech typical of Broca's aphasia and the difficulty with comprehension that's typical in Wernicke's aphasia. The individuals often only have a few utterances available to them, and these are used appropriately and inappropriately, and these few utterances are referred to as stereotypies. So these stereotypies are generally produced involuntarily, and they carry little to no meaning. As you might have guessed already, in individuals with mixed or global aphasia, reading and writing skills are seriously compromised. And global aphasia is generally considered to be the most severely debilitating of all the aphasia syndromes. Additionally, their repetition skills are poor. I also included this visual, you can see to the right, and that shows a brain scan of someone with mixed or global aphasia. So you can see that both the anterior and posterior language regions of the brain are affected by the large lesion. Now I'm going to speak briefly about the transcortical aphasias. This will go through a little bit faster because they parallel other aphasias that we already learned about. So we'll start with transcortical sensory aphasia. This parallels Wernicke's aphasia. But repetition is entirely spared because the lesions are beyond or trans the language area of the brain. Transcortical sensory aphasia is characterized by poor comprehension with fluent but semantically empty speech, except when they are repeating. So earlier in the presentation, I made it a point to discuss how repetition skills are severely impaired in individuals with Wernicke's aphasia. And that was so that I could highlight later on here when we talk about transcortical sensory aphasia that repetition skills are intact. So that's the difference between transcortical sensory aphasia and Wernicke's aphasia. They do run parallel, but repetition is kind of what sets them apart. So on the other hand, we'll now discuss transcortical motor aphasia, which parallels Broca's aphasia. Patients with transcortical motor aphasia will initiate little language, and what they say will be fragmentary, although not agrammatic, as seen in Broca's aphasia. So in Broca's, we have that agrammatic telegraphic speech. In transcortical motor aphasia, we have this little sample here where the questioner asks, "Can you tell me the story of what brought you to the hospital?" And the patient responds with very little language, just simply a stroke. And as in Broca's aphasia, their comprehension is relatively intact. Now, there are two other cortical syndromes that I just want to touch on. The first is pure word deafness. So that's an inability to make sense of oral language in a person with normal hearing. So, for example, when an individual is asked, "What did you eat for breakfast?" the patient may respond, "Breakfast? Breakfast? It sounds familiar, but I don't know what that is." And this occurs due to an injury to Heschel's gyrus, which is an area of the brain located in the primary auditory cortex, and it's the first cortical structure to process incoming auditory information. Then we have alexia, which occurs when visual linguistic stimuli are not processed. An individual with pure alexia can speak and understand language, but is no longer able to read. And this is caused by an injury to the angular gyrus. So this concludes our second lecture for week 2 called Aphasia, Classification of the Syndromes. I know that this was a ton of information, but I hope this video and the PowerPoint are helpful for you guys. And just like any other time, if you have any questions, please post them in the students' question forum on Canvas. Thank you for your time.